Hi, my name is Austin Larson. I'm a physician at the University of Colorado School of Medicine. I practice at Children's Hospital Colorado. I'm a pediatrician by training, a medical geneticist and a biochemical geneticist. I help to direct the Mitochondrial Care Network clinic here in Colorado, as well as seeing patients with the genetics and metabolic service here at our hospital. I do see adult and pediatric patients, specifically in mitochondrial disease, but my primary area of expertise is in pediatric genetic and metabolic diseases. So I'm going to talk to you today about the COVID-19 pandemic and what the implications are for patients with mitochondrial disease. So I want to acknowledge that this is really an unprecedented time that we're in. We are experiencing a once-a-century pandemic that is currently going around the world, impacting people in so many ways in terms of their health, their finances, their social circumstances, their family circumstances. Really a disruptive time for a lot of people and a very difficult time. So I think it's important in a venue like this mitochondrial meeting that's now virtual and taking the place of what had been a regular annual meeting to discuss mitochondrial disease. I think it's important to take this opportunity to talk about what we do know about COVID-19. Think about how it might interact with mitochondrial disease, and to discuss what the recommendations would be for patients that have mitochondrial disease. I'm really going to focus a lot on this first question. We have a really nice lineup today of talks that are oriented at patients and families, and a number of the other speakers We'll touch on specific recommendations for patients with mitochondrial disease. And so I do want to focus really on the question of what we know about COVID-19, and hopefully you can use that as an introduction in terms of the questions, both for me during the Q&A session that I'll do, and also with other folks that will be speaking today. I want to let everyone know that I'm recording this on June 17th. This is a pretty quickly moving situation, and we may know things in a couple weeks when you're viewing this that we don't know now. And there may be an opportunity to talk about a few updates during the live Q&A session that we have then. So COVID-19 is the word that most of us use to describe this pandemic. And what COVID-19 stands for is the coronavirus related disease that started in 2019. So this did start in late 2019 in China. Obviously, the manifestations for most of the world have happened in 2020. COVID-19 refers to the clinical syndrome or the disease that results from people who are infected with a virus called SARS-CoV-2. So SARS-CoV-2, the name comes from the severe acute respiratory syndrome. That name was coined 17 years ago during a prior outbreak. And that prior virus is now called SARS-CoV-1. The virus that's currently circulating and causing this pandemic is closely related to that virus. So it's been called SARS-CoV-2 because they're so closely related. Those two viruses are the most closely related, but there are other viruses in this family of coronaviruses. So coronaviruses are so named because when you look at them under a microscope, they look like a crown. So corona means crown. And these spike proteins that stick out from the virus, they give that appearance of the crown, and hence the name coronavirus. So there is this current coronavirus, SARS-CoV-2, that is in a pandemic stage, meaning that it's circulating throughout the world. There are also what's called endemic coronaviruses. So there are 4 separate coronaviruses that are considered endemic, meaning they don't ever really go away. since we've known about coronaviruses, they've been circulating in the population. They circulate at relatively lower levels. They cause relatively milder illness in comparison to SARS-CoV-2 and SARS-CoV-1. And they often cause symptoms of a common cold or a respiratory infection, and most frequently in children in comparison to adults. So if you think about the difference between SARS-CoV-1 and SARS-CoV-2, the reason that one of them was successfully contained and the other became this global pandemic is actually a little bit paradoxical, in that SARS-CoV-2 causes a somewhat less severe clinical illness than SARS-CoV-1. Because SARS-CoV-1 was so severe, people became symptomatic sooner after they became exposed to the virus. They were able to quarantine themselves. They were also so sick that many of them weren't out going to work or walking through cities, riding public transit, things like that. Whereas with SARS-CoV-2, there's a significant fraction of people that have quite a mild illness. And as a result of that, they are traveling internationally, going to work, things like that. And that's probably the reason that SARS-CoV-2 or COVID-19 has become this worldwide once-a-century type pandemic, whereas the original SARS was able to be contained. It still significantly affected cities like Toronto and Hong Kong, but it didn't become this global pandemic that we're currently experiencing. So the way that SARS-CoV-2 affects the body is that it's initially a respiratory infection. So the virus enters the body through the nose or mouth or eyes. It infects the cells of the upper respiratory tract. It spreads to the lower respiratory tract, and it causes cell damage. So that initial experience of being short of breath and coughing, that's related to that viral infection of the viral propagation and cell damage that's happening. However, with SARS-CoV-2, we now know that there are a number of secondary effects, and in a lot of cases, those secondary effects may actually be more clinically relevant than the primary infection. So the SARS-CoV-2 virus spreads to blood vessels. It can affect the heart and the kidneys and the digestive tract. And potentially most importantly, it causes in some people a really robust immune response. The chemicals that mediate that immune response are called cytokines, and those cytokines can sometimes rise to such high levels that that's something called a cytokine storm. And so a cytokine storm has been documented in a lot of the people who have really severe illnesses, who are in ICUs, or who have a fatal case of COVID-19 as the driving process. So for a lot of folks, it's that secondary immune response rather than that primary viral infection that may be most clinically relevant for what they're experiencing. The patients that are hospitalized with COVID-19, the vast majority of them have fever and cough and shortness of breath. Smaller numbers of people have muscle aches, diarrhea, nausea and vomiting, some neurologic symptoms like confusion. We know, and I'll go into this in more detail, that people with underlying health conditions such as chronic heart disease, diabetes, chronic lung disease, chronic kidney disease, are at higher risk of being hospitalized and are at higher risk of having severe outcomes related to SARS-CoV-2 infection. This is a screenshot from the Johns Hopkins University Coronavirus Resource Center. The screenshot was taken on June 16th. And at that time, there were over 8 million documented cases around the world and over 440,000 deaths around the world that have been attributed to COVID-19. That pandemic is continuing to propagate. There may even be an acceleration recently in the number of people who have been documented to have the illness around the world. The shape of the pandemic has been different in different populations. So this is a graph from a website called Our World in Data. This is the number of total daily deaths, starting the count at the day when there were 5 new deaths reported related to COVID-19. So you can see that the United States had a really rapid rise, a really high peak, and we're well below that peak now. We're approaching 100 days from our first day when we had 5 people that died of COVID-19. Some other countries like Brazil and India are now becoming the epicenter of the pandemic. Russia would also fall into that category. They've seen a slower rise, but now are at significant numbers of folks who are infected and folks who are dying due to COVID-19. Some of the other lines on this graph are the United Kingdom, Italy, and Germany, all of which had significant peaks relatively early on and are well below those peaks now after a couple months of really intensive interventions in those countries. So when we define cases, it's really important to understand what types of testing can be done for SARS-CoV-2. There's really 2 main ways that we can document a case. So the one that most people are probably familiar with is the nasal swab. So that's a test where you put a Q-tip or a swab inside the nose, try to brush up against the cells of the upper respiratory tract, and then you do a test called PCR, or polymerase chain reaction, where you're looking directly for genetic material from the virus. And that will be a positive test if you are acutely infected, if you currently have the virus. There's some debate about, some people have lingering positive tests for 3 or 4 or more weeks. There's some debate about whether there's significance of that or whether those people just kind of have some lingering genetic material from the virus. But it's important to know that that test will be negative if you miss the window when a person is acutely infected. And so PCR testing may result in significant undercounting. There also may be technique issues. So if someone didn't swab well enough or didn't run the test correctly, you can have a false negative test. There's another test which has been developed a little bit later, which is a blood test to look for antibodies to see if you previously had the virus. So this test would be negative if you're acutely infected, but then would become positive later on, and that would be a documentation of the fact that the immune system has been activated and has responded to the virus. So you get different information from these 2 tests. There's no perfect test. They both have benefits and drawbacks. And I want to talk a little bit about the implications of just relying on that PCR test. So there are 2 kind of case studies that I want to point to that I think help to make our understanding of this data a little bit more nuanced. So there was an aircraft carrier that got a lot of publicity, the USS Theodore Roosevelt, where a lot of the sailors on the carrier were impacted by COVID-19. They were being tested quite frequently, but cumulatively only about 25% of the sailors tested positive. There were about 5,000 sailors on the carrier. There was a follow-up study of the sailors that had been on the carrier, and they found that 60% of them had antibodies showing that they had been infected at one point. So what that tells us is that the PCR testing, even with pretty intensive testing of a confined group of folks, it can result in a significant undercount. And that undercount is important because that's what gives us the denominator to understand what is the case fatality rate and understand how it's impacting different populations differently. There was again, a well-publicized outbreak of SARS-CoV-2 infections in northern Italy. The city that was most heavily impacted by that is called Bergamo. So Bergamo is just outside Milan. And there were over 6,000 deaths in Bergamo. And that was resulted in a very high case fatality rate based on the number of documented positive PCR tests. But in a more recent follow-up, looking at antibodies from that population, it looks like 60% of the population of that city of 1 million people had been infected at some point. And given that that rate of infection was much, much higher, that means that the fatality rate was actually a tenth of what it appeared to be, given the breadth of folks that truly had the disease, but either had a false negative test or a PCR test at the wrong time, or just never got tested. So taking that data, we can generate an infection fatality rate, meaning the number of people who die as a fraction of those people who had infection. And in a place like Bergamo, Italy, where they're a relatively older population with more comorbid illnesses, the fatality rate appears to have been around 1% if we rely on that antibody number, indicating that a larger segment of the population had the infection than we initially thought. On the USS Roosevelt, there was one death out of almost 3,000 infected sailors, meaning that's a 0.03% infection fatality rate, indicating that that population is relatively less likely to have severe illness. So the population on a carrier would be much younger, much healthier individuals. So that probably gives you a sense of the just how widely variable the severity of this illness can be in different populations. So as I mentioned, one of the things that is most indicative of the likelihood of a severe illness or the lack of likelihood of severe illness is age. So those that are older are much more susceptible to severe illness. We know that male sex and the prevalence of underlying illnesses are also significant risk factors. So I can talk a little bit about my experience working at a children's hospital. They have been collecting data here, testing every admitted patient. And what we found is that our data have been pretty consistent with those data that have been generated around the world, showing that children are much less likely to be infected, and when they are infected, much less likely to have severe illness as a result. So some recent papers that have come out have started to think about the trade-offs that we're making in terms of the societal interventions that we put into place. And the question of whether or not to close schools is a really important one. So when we think about the trade-offs that we're making, we're really impacting children in terms of their education. We're impacting families by kids not being in school. And so it will be important over the next couple months as we make the decisions about whether to reopen schools in the fall and how to reopen them, to use data like the data that we're generating here at Children's Hospital, like the data that have been generated in other countries about the rate of infections among children, the transmissibility of infections between children, and the rate of severe illness with children. So I'm not here to tell you right answers, but we're making trade-offs, and we're making decisions as individuals, we're making decisions as healthcare providers, as societies, in terms of how we want to respond to this. And I do think that it's important that we have a really nuanced appreciation of the data when we make those decisions to try to make the trade-offs as optimal as we can. So these are some data from Colorado. Again, this is a screen capture from June 16th. So this is a rapidly evolving data set. But I do want to draw your attention to the number of positive tests among children less than 9 and between 10 and 19. This is fewer than 5% of the overall positive tests, whereas folks in that age range are 25% of the population here in Colorado. So clearly significantly underrepresented. The other thing that you can see, this blue bar is folks that are hospitalized. The gray bar is folks that tested positive but weren't hospitalized. And the dark blue bar on top is the number of deaths. And you can see that both the rate of hospitalization and fatality increases with age. Just to give you a sense of the progression of this epidemic with time, one way to look at it is the test positivity rates. So of all tests that are done, what fraction of them are positive? So at the peak of the epidemic here in Colorado, that was mid-April, a quarter of all tests that were done were positive. And this is PCR tests. Whereas now it's more like 2% are positive. So we're in a lull here. I think everyone expects that rate to increase somewhat as the restrictions are lifted, as more people are venturing out, getting out of the home, going back to work. And I think, again, in terms of the trade-offs that we're making, it's that question of what are the things that we can do that are relatively low impact, that are just kind of smart ways to modify our lives a little bit to decrease that likelihood of transmission, decrease the likelihood of getting the virus and getting the illness associated with it. Looking at that case fatality rate by age, we see the same pattern in every country that's been looked at. So this is another chart from this website, Our World in Data. You can see that the case fatality rate is extremely low in children, quite low in young adults, but then as you get to folks in their 50s, 60s, 70s, and 80s, there's an increasing rate of mortality related to the virus. And I want to emphasize that these case fatality rates, again, are likely an overestimate because we're undercounting that denominator of the total number of cases based on just the PCR test. So the absolute numbers are probably an overestimate, but the relative numbers of different age groups, I think, is not in question at this point. So this is clearly a much more severe virus in the way that it impacts folks that are older than folks that are younger. Looking at another set of data, the fatality rates and the rate of severe illness are much higher among those who have comorbid conditions than those who don't. So again, I think these numbers are likely to be overestimates, but the relative numbers in comparison to one another is what's important here. So folks that have cardiovascular disease, diabetes, chronic lung disease are clearly at much higher risk than folks that don't have those conditions. And as it relates to mitochondrial disease, cardiovascular disease like cardiomyopathy, cardiac arrhythmias are much more prevalent in the population with mitochondrial disease than those that don't have mitochondrial disease. Likewise, diabetes is clearly associated with mitochondrial disease, as is chronic respiratory disease in the form of respiratory insufficiency or respiratory muscle weakness related to myopathy. That's clearly something that we see in folks with mitochondrial disease. So the relative risk of COVID-19, again, not the absolute numbers here, but the relative risk in comparison to the population, I think is really important in terms of helping us to make good decisions. As it relates to pediatric cases, I talked earlier about there being really two components here of SARS-CoV-2. There's the infection, but then there's the immune response to the presence of the virus. And it appears that in children, that immune response is relatively more significant in terms of the children that do, those few children that do have severe disease related to this virus, many of them, it's only the immune response and not that primary viral infection that's resulting in the severe illness. So there's this phenomenon called MIS-C, which is multisystem inflammatory syndrome in children, which is an inflammatory syndrome that we see usually after the acute infection is completely gone, weeks later. We see that kids are getting very inflamed in a way that's affecting their hearts and their blood vessels. It can look like some other inflammatory conditions called toxic shock syndrome or Kawasaki syndrome. And it's clear that for children, this is the immune response to that viral illness and not the viral illness itself. And that impacts the way that that we go about treatment. So for the cases that I'm aware of, those kids have been treated with the medications that reduce the inflammation and try to tamp down that cytokine storm or the other inflammatory processes that are causing the symptoms. So this is something that we see in a small fraction of the children that have been infected. So what is a patient with mitochondrial disease or someone without mitochondrial disease? What are we to do? So we know that we have some effective ways to prevent infection. So wearing a mask clearly reduces the likelihood that two people will transmit the virus between them. That's probably primarily the person that potentially is infectious, but maybe has no symptoms, preventing them from spreading the virus. So that's really the primary impact of the mask. It's less benefit for the uninfected person and more the person who may have the virus but is asymptomatic, preventing them from spreading it. We know that social distancing works, that staying home works, but we also know that it takes a huge toll. So it has really significant economic implications and implications in terms of our general well-being. So not being able to see family members, not being able to see friends and colleagues is really impactful. And so to the degree that we can figure out ways to have those social interactions and to continue to do our jobs, but in ways that are safer with regards to viral transmission, I think that's really important. Folks that have symptoms need to not expose themselves to other people. So we have some social norms in different environments of not taking sick days or not letting a cold get you down. And at least for the short term, that social norm needs to change. And we need to make sure that people who are potentially infectious are not exposing themselves to other people in public or in the workplace. Hand sanitizer and hand washing, good hand hygiene clearly works as a way to prevent transmission. So these are all things that I know everyone has heard time and time again, but these are the interventions that we have right now in terms of being able to slow the spread of this virus. So what can we do? We will have a talk later today about telemedicine. So helping people to continue to get their health care in the home rather than coming to a hospital where there may be other infectious people. That's something that we've worked really hard on at my institution and at institutions around the country and around the world. There's a group here with the Mitochondrial Care Network, led by Dr. Parikh and Dr. Kara, who have really made telehealth with regards to mitochondrial disease a point of emphasis, and they'll talk about that later today. So I encourage you to stay on the call here and listen into their talk. As I mentioned, we know about these things that are effective, but we also know that there are significant costs associated with them in terms of our social well-being and our financial well-being. And so as we learn more and more about the transmission of this virus and who's most likely to be impacted, we can start to make more nuanced decisions about the activities that we engage in. So mitigating risk, obviously the risk is lowest with virtual interactions like the one that we're having now. But mitigating risk might be something like socializing outdoors with a very small number of people. Hopefully those people are not ill. They themselves are taking those precautions that we talked about on the last slide and being careful about their own exposures. I think with some careful thought, we can have those social interactions, but in a pretty low risk way. In terms of deciding what societal interventions we put into place, or just personally what kinds of exposures we want to engage in, we can learn from what are called super spreading events. So super spreading events are places and times where many people have become infected by the virus. So many of those super spreading events have happened in meatpacking factories. So that has something to tell us about what are the circumstances in which the virus is most easily transmissible. Meatpacking factories are cold, they're enclosed, they're indoors, the people are working closely together. They're sometimes working with power tools that have the ability to spread air really broadly. I'm not an expert in occupational exposures, but that's being studied right now, and learning from that extreme case where the virus seems to be really easily spread, and sort of backtracking from there to figure out what are each of the variables that we can tweak, what are the incremental changes that we can make in our environment and in our circumstances that can make the virus less transmissible. This on the right here is a picture of a choir practice. So one of the most well-publicized super spreading events was a choir practice in Seattle, Washington, where one individual infected over 90% of the other members of the choir just in one choir practice. And that's probably a function of being indoors, of projecting. So the louder you're projecting your voice, the more distantly you're spreading those viral particles. Everyone around them is breathing deeply as part of their own singing. So that, again, is a very, very high risk scenario. And we can learn from that in terms of the interventions that we make going forward to be as safe as possible. In addition to our understanding of how the virus spreads and what we can do to decrease the risk of transmission, we're also getting better at studying and developing experience in how to treat people who are acutely infected and who are hospitalized. So I just checked clinicaltrials.gov this morning. There are over 2,000 studies listed that relate to COVID-19. This is a scenario, it's unfortunately in some ways it's kind of the opposite of mitochondrial disease in that it's something that really lends itself to clinical trials. So the outcomes that we care about with regards to COVID-19, they happen really soon. They're really objective. Is someone on a ventilator or are they not? Are they hospitalized or are they not? And those outcomes, yes or no, to those questions, that happens within a matter of days. We also have a really large number of people, right? Over 8 million people around the world, and many multiples of that that just have undocumented infections to draw from. So it's really an opportunity to advance the science very, very quickly, given that all of the preconditions are in place for pretty easily conducted clinical trials. Not to minimize the work and the expense that goes into that at all, but again, we have an opportunity here over the next couple months to make really rapid improvements in how we manage this condition. So this is a kind of some late breaking news out of the UK that came out yesterday. There is a pretty carefully conducted randomized trial of people who had standard care for COVID-19 and those that had steroid, dexamethasone, on top of their standard care. And they found that there was a significant risk in the decrease in the risk of death and in those folks that took the dexamethasone. So those little tweaks, those incremental tweaks like that are going to add up, and we're going to get better and better at managing this condition. We're going to get better and better at preventing the spread. So that's the goal. That's what the entire medical and scientific infrastructure around the world is mobilized for right now. And we're starting to make progress, and we're just starting to see the benefits of that. So specifically for folks with mitochondrial disease, COVID-19 has the potential to be a really significant illness. So folks with mitochondrial disease have a lot of those comorbidities that have been overrepresented in folks with admissions related to COVID-19. Things like cardiomyopathy, cardiac arrhythmias, diabetes, hypoventilation. All of those things are likely to be risk factors with regards to a higher potential for severe illness. That said, we can be aware of those complications, and we can actively implement management strategies to account for them. So one thing that we can do for folks with mitochondrial disease is to avoid prolonged catabolism. So there are different strategies of nutritional management for adults and children in ICU and hospital settings. In general, for folks with mitochondrial disease, we want to be more aggressive about providing calories. If someone's unable to get fed enterally, then that should be a parenteral or intravenous administration of calories like dextrose containing fluids and fats. We want to make sure that we're actively evaluating for potential complications and taking those into account. Things like neuropathy, myopathy, changes in the hormones. We want to make sure that we're thinking one step ahead about the potential complications that a patient with mitochondrial disease might have. I want to talk a little bit about the way that I approach this. If I'm speaking with an intensive care physician or a hospitalist physician who's taking care of one of my patients with a metabolic or mitochondrial disease, there's a middle ground to be struck. So the mitochondrial disease can't crowd out every other consideration in terms of the management strategies. So a good example of that is that when I am speaking with an intensive care physician, I might recommend that they start dextrose-containing IV fluids. And the response might be, oh, we really need to restrict the amount of fluid this patient is getting because they have pulmonary edema or they have edema elsewhere in their body. So then I might say, okay, so let's maybe change some of those calories to fat, and let's increase the concentration of the dextrose so that we can administer it in a smaller volume. And I think it's really important that there's a back and forth, that we as mitochondrial physicians understand the goals of the intensive care physician, what they're trying to accomplish. They have a lot of intuitive expertise as it relates to patients in particular circumstances in the ICU. And it's important that it's a two-way street in terms of the recommendations that are made, that we as mitochondrial physicians can provide them with new considerations about maybe new diagnostic studies or new evaluations to get, some changes in management, but we need to make sure that that still takes into account the expertise of that physician who's primarily caring for the patient in the ICU or on the hospital floor. So I would say that the main thing that can be done is just to make sure that those lines of communication are open and that conversation is ongoing and that it's adaptive to the circumstances of the patient. As the circumstances change, that conversation needs to change in terms of what the goals are of care. There's a really nice paper, Dr. Parikh, who you'll hear from later today, is the first author on this paper that provides a consensus statement about standards for care for mitochondrial disease. So I I want to stop here and thank you for listening to this presentation. Thank you for being engaged and involved in the mitochondrial community. And I'm looking forward to the other talks that we have in the next couple hours. I think that those will be really informative, and I'm happy to take any questions that you have for the next 15 minutes or so.
So we are now live with Dr. Larson, and I just want to handle some housekeeping issues. If you're watching on full screen, you're not seeing the chat, and you want to see the chat, it's probably very simple. Just minimize your screen. So Dr. Larson, one of the questions I want to start off with this morning is the recent spike in cases. Why do you think that is, and should patient families be very concerned about that?
So the recent spike that we've seen has really centered in kind of southern and western states. So we've seen Texas, Florida, Arizona set new daily maximums. So they're having their highest ever number of daily cases. It's a little bit hard to know exactly why that is. I'm not an epidemiologist. Virology is not my training, but I'm happy to speculate a little bit. My guess would be it's probably a combination of two things. So the increase that we're seeing is in really hot places. So those are places where people are going indoors during the summer, whereas the earlier spike that we saw in March and April was in places that people are indoors during that time of year and are more likely to be outdoors in the summer. So in terms of the super spreading events that we've seen, they almost exclusively happen indoors. And I think it's pretty well established at this point that the risk of transmission between two people is much higher indoors than outdoors. So I think that's probably a big component, is just the relative amount of time that people are spending indoors versus outdoors around other people. In those states where we're seeing the big increase, I think people are more likely to be indoors during the summer. I think the other piece is probably just kind of fatigue with the measures that we talked about that are effective at limiting the spread between two people. So most impactful is not seeing people at all, but that's not sustainable for the long term. And things that are still impactful and probably are more sustainable are things like mask wearing, kind of alternating work schedules, people working from home part-time and being in the office part-time, so the total number of people you're exposed to is lower. So I think there's probably some fatigue with those measures, and as the reopening has happened, so in Arizona and in Texas and in Florida, the spike has coincided with reopening places like bars. So a bar is a really high risk situation. You're close to other people. People are constantly putting things in their mouth. It's loud, so you're speaking. I talked about that choir practice, which is one of those incredibly high risk events, probably because people are speaking or singing. So they're singing loudly. They're projecting those viral particles more distantly from themselves. So Texas today just announced that they're closing all the bars again recently after reopening them, because probably a bar is a very high risk situation in terms of, again, putting things in your mouth and then speaking loudly, projecting, being indoors, being in close proximity to a lot of people. So I would say that's kind of my speculation, but I think that's fairly reasonable to think that that is the reason that we've seen a significant spike in the last week or so. And it was pretty striking for me just to watch that recording that I did 11 or 12 days ago, and to know that we're unfortunately definitely on a different and worse trajectory than we were just that short time ago. So In terms of how people respond to that, the point that I was trying to make during this talk is that there's almost nothing that's risk-free. So it's a personal decision in terms of how you want to navigate the risks that exist. There are not absolutes here. So like seeing one family member who you haven't seen in 2 months, seeing them outdoors, being 6 feet away from them, and everyone wearing masks, and that family member has been very careful in terms of how they're going about their lives, that's a pretty low risk situation. And I would say that there's significant benefit of seeing that person, if that's someone that you love and someone that you care for. Going to a bar in Houston, Texas right now would be a very high risk situation to put yourself in, and you have to kind of calculate those risks and benefits in terms of how you're going to change your life and how you're going to impact your life in response to this.
Do you think, in your estimation, we've heard about a second wave coming in the fall. Are we not yet over the first wave, or is this spike consideration of a second wave?
Yeah, it's regional. So we're seeing a different. I showed the sort of trajectory of the epidemic in different countries, and we see different shapes of that. And even within the United States, we've seen very different shapes. So those states, Arizona and Texas and Florida, they didn't see a spike anywhere near what New York and New Jersey saw in March and April. And now they're seeing that spike. So it's regional. I don't think that we can talk about an overall first wave or second wave. It's sort of a lot of overlapping waves that happen in different places.
Do you think that these increases in cases that we've seen over the last week or so, should our patient community members, should they be more diligent in their practices to stave off any kind of an infection, or are they able to relax a little bit? I mean, what's your best thought on that?
I would say that it depends on your personal circumstances. So we know that children are at lower risk than adults. We know that people who have maybe cardiac or pulmonary or endocrinological manifestations of mitochondrial disease, we know those folks are at higher risk than folks that don't have those manifestations. We know that the risk is higher in different parts of the country as compared to other parts of the country. I talked about the specific environmental exposures that are associated with a very high risk of transmission versus a low risk of transmission. And so, I can't give a blanket statement about that. But I do hope that having these discussions, that understanding, what are my personal risk factors? What is the risk factor in my geographical area? And then what are the risk factors associated with a specific environmental circumstance that I'm putting myself in? Those are the sort of three things to take into account in terms of how am I going to behave? So, someone in Arizona right now, there's probably a lot of community spread going on. And I think it makes more sense to be more cautious in Arizona right now than 2 weeks ago. I think that you're getting relatively more benefit of that caution, of those interventions that you're putting into place now, based on the amount of community spread. So, there's not a one-size-fits-all solution. I think it's a good discussion to have with your physician, with your family members, about what risks do you want to take, what risks don't you want to take, and just kind of how to navigate that.
So a lot of parents are having questions about resuming school this fall. What are your thoughts on that? Is it a regional thing as well?
Partially, but I think it's it's important to take into account the age-related risk of this condition. So the risk to the child appears to be relatively low. So if you compare this year to previous years, I mean, in terms of the children that I care for with chronic illness, the most significant risk to them on a month-by-month, year-by-year basis is respiratory viruses. And there are dozens of respiratory viruses that my patients get that sometimes make them really seriously ill. So things like RSV, influenza, human metapneumovirus, the other coronaviruses, the 4 other coronaviruses. So, just to give you an example, a couple months ago, I had a patient in the ICU with mitochondrial disease who was seriously ill, and they had one of the other coronaviruses, not the SARS-CoV-2 or COVID-19 coronavirus. So we won't truly know for a little while what the relative risk is this year as compared to prior years for children as it relates to the kind of cumulative risk of respiratory viruses. But it's certainly probably only slightly higher, if that, as compared to adults for whom it's much, much higher this year than prior years. So the relative risk for children is a much lower degree of relative risk than the relative risk for adults, and particularly older adults. So I have patients whose kids, they feel like their kids get a lot out of school. Their kids enjoy school. They're learning well. They're thriving in school, but they just, if they go to school from, in December, January, February, and March, they just end up getting sick all the time. They get respiratory virus after respiratory virus. They get hospitalized. They end up on IV fluids. They have setbacks in terms of their overall health. So I have families who every year they elect for their kids to go to school in the relatively low risk times of year for respiratory viruses, and then stay home during the high risk times of year. And so, again, it's a personal decision. It relates to what the risk is for the child, what the degree of cardiac disease, of pulmonary disease is, of endocrine disease. There's not one right answer here. So there are probably children who are at no higher risk this year than other years. And I think talking through that with your physician, if your child is someone who benefits a lot from school, they're clearly thriving there, it's an important part of their well-being, I think that there's a strong case to be made that given the relatively low risk to children, and in particular children without those comorbidities, I think you can make a case for attending school. You could also make a case for a child with significant cardiomyopathy. Maybe it's just not worth the risk this year. And so that really is going to be a case by case. It's going to be a personal decision in terms of just thinking about, being smart, thinking about the information that we have in a nuanced way, and just coming to the best kind of risk benefit calculation that you can between your family and your physician.
Yeah, this year really a lot parents have to consider, and talking with their physician about these issues. I want to move on to adults. When will we know in patients that had COVID-19 the full impact of that? I mean, when will we have that information on what the actual impact to the respiratory system or to other systems? Is that something that's going to take a while?
Yeah, so there's a question in the chat which brings up a great point, which is the example of polio. So the long-term manifestations of poliovirus and the paralysis that resulted from that was, that wasn't recognized for a significant period of time. I think we're starting to get some data about that. The data that we have are imperfect in the moment, but to give you an example of the data that we are starting to get, this multisystem inflammatory syndrome for children, the MISC. So that there was clearly a spike of MISC cases about a month after the spike of acute coronavirus illness in New York. So there was clearly a temporal relationship that was delayed by about a month. We do know that that there are patients whose lungs never recover. So there are people who get such severe pulmonary illness. There was a report just a couple weeks ago of the first woman to undergo a lung transplant related to coronavirus. So her lungs were so damaged that they were never going to recover. And the only way for her to get out of the hospital was to undergo a lung transplant, which is an incredibly major intervention. So there will be a fraction of patients who don't ever get back to their prior pulmonary baseline, but that's also true of other viruses as well. So I think we're still in early days in terms of understanding the relative risk in comparison to the sort of ongoing risk on a month by month, year by year basis. You know, roll the clock back a year. What was the risk to any particular patient from the viruses that were circulating at that time? There was risk there. I mean, that's the major complication that I manage in my patients is respiratory viruses every year. But it's absolutely clear this year that adults are at substantially higher risk, that we're seeing significantly excess hospitalization, significantly excess mortality, unfortunately, related to COVID-19 in adults. And it is, I'll say it is clear that there's some fraction of patients who have long-term manifestations, even if they've recovered from the acute illness. I don't think that we know, we haven't had enough time yet to know what fraction of patients that is. So if the mortality rate is 1% in a high-risk population, but the morbidity rate in terms of having long-term manifestations, is it 2% or 5%? You know, we don't have the data right now to be able to answer that question in a really well-informed way.
We have a number of questions surrounding masks and doing everyday things, so I want to get to those. So let's talk about the masks. One of the questions is, are there N95 masks for younger children? Do they make those? And also, what should patient families use if they can't find that N95 mask and they need to get out?
Yeah, so there are different types of masks. The masks that you see, you know, when I am out for a walk or I go to the grocery store, the most common thing I see is a cloth mask that people are wearing. That cloth mask, the primary impact of that is to reduce the distance that I'm spreading viral particles if I am infectious. So hopefully if I'm symptomatic and infectious, I'm not going out. But we know that there are some fraction of people who are truly asymptomatic. So for those people, wearing that cloth mask or that kind of standard surgical mask, that is preventing them from spreading as many viral particles. It is reducing the probability that any person in their vicinity is going to get infected. And that's the primary impact of those masks. Probably has a little bit of benefit for the person wearing them in terms of preventing you from getting infected, but not as much as you would hope. So by wearing a mask, I want to emphasize this, by wearing a mask, you're doing a service to the people around you. That is the primary thing that is going on when you're wearing a mask. And I think that mentality can help to propagate mask wearing a little bit. You're doing a good for the people around you. And you know, some people I think maybe don't wear a mask because they feel low risk, and I don't, I don't feel at risk for myself. I want to take this risk, but it's not about you. It's about the people around you. So I want to emphasize that in terms of the cloth masks and the surgical masks. The N95 masks are kind of the opposite end of the spectrum. So that's to prevent inhaling those viral particles. The key about N95 masks is that we as healthcare providers, when we get fitted for those masks, we go through a process to make sure that there's a seal all the way around the nose and mouth. So that's a somewhat involved process to make sure that the specific brand of mask works with the shape of your face. If you have facial hair, you need to get rid of that to get a seal. There are a lot of considerations. So it's hard, and there are a lot of masks online that say they're N95 masks. It's hard to know that you have a mask that has the seal that would mean that mask is performing in that way of preventing the inhalation of the viral particles. So I'm just not enough of an expert in the specific types of masks to comment about a particular brand or a particular type of mask that would, form the right seal for a child-sized space. I'm sorry, I can't provide an educated response on that.
No, I think the advice that you gave is great. Yeah, I do know that they have to be fitted, so you'd have to find somebody that could fit it for a child. Let's talk a little bit about daily living. There's a question about getting haircuts. I know here in Pennsylvania, we had to wait until a certain phase to get haircuts, and I'm sure there are restrictions across the country. What precautions should a patient or family member take if they want to go get their hair cut, dyed, whatever you have to do?
Yeah, so you're taking some risk when you do that. There's no doubt that your risk is higher than it would have been had you not gone to get that haircut. It's a question of, what is the relative risk that is reasonable. So the thing that comes to mind, I haven't gotten a haircut out of the house in the last few months. Thank you to my wife who's been doing that. I did go to the dentist recently. So just to kind of give you an example of what that was like. So, when I went to the dentist, I got a call a couple days ahead of time. They said, here's how this is going to work. We don't have a waiting room. So you sit in your car in the parking lot. You call us when you're sitting in the parking lot. You have to be wearing a mask from the time that you leave your car until you're sitting in the dental chair, and only you and the dentist are the only two people in that room. You can't have other people with you. If you're sick, cancel right away. We'll accommodate you. Any symptoms at all, we don't want to see you. They conveyed that they're being very careful in terms of their employees providing paid sick days. So all of those things were reassuring to me. So the risk was not zero of me going to the dentist, but the fact that those precautions were in place, that reassured me to the point that getting my teeth cleaned is a calculated risk that I'm willing to take with those precautions in place. So I think that's the thought process. And everything that you do, there's some level of risk associated with it. Going to the grocery store. So the things that you can do to mitigate the risk of going to the grocery store are either have your groceries delivered or have a family member do that grocery shopping for you. So I've been doing grocery shopping for my parents who are in their late 70s for the last couple months, and leaving the groceries on their doorstep so they don't have to go to the grocery store, so they don't have to take that risk because they are in a very high risk age range and I'm not. So I feel more comfortable with myself taking that risk than my parents taking that risk. So those are that's the kind of thought process. And it's a strange time to be in, to sort of be making those calculations with each of your sort of daily activities. But that's kind of the scenario that we're in right now.
And I had the same situation when I went to primary care doctor just for a checkup that you have to wait in the parking lot. And that brings me to the next question that we have. What precautions should patient families take if they need to see their primary care physician, or if they need to go to the dentist? And I know we're having a topic on telehealth coming up. And the follow-up to that would be, at what point do you feel like you need to see the physician in person and not through telehealth?
Yeah, so I'll kind of differentiate two different scenarios. So one scenario is if you are acutely ill and you may need an IV, or you may need oxygen or some kind of respiratory intervention. In that scenario, there's no avoiding the fact that you need to be physically present to get those interventions. Most of what I do in terms of the clinic visits that I have with my mitochondrial patients and other genetic and metabolic patients is we're primarily talking about lab results. We're talking about, I've had this exact discussion that we're having right now. I've had that with dozens of patients over the last couple months, just helping each patient to sort of think through their personal risk, the risk of their family members, the things that they just need to do in their daily life. What are the risks worth taking? What are the risks that are not worth taking? So that's been a substantial portion of the healthcare that I've been providing, is to have that discussion. And I feel like I can do that effectively by telehealth. There's a pretty small fraction of visits that I need to do in person. And I think as a patient, it's worth asking, if you need to go to the physician and they offer you an in-person visit, it's all, there's no harm in asking, hey, do you offer telehealth? I think this question is something that can be addressed that way. But I think we have shown, looking at the epidemiology of SARS-CoV-2 or COVID-19 spread within healthcare organizations, I think that, we can feel pretty good that the interventions that are in place in most healthcare settings have been substantially effective at reducing the risk of transmission in those environments, because we just, we haven't seen the spike of cases associated with clinics and things like that, just based on the, the mask wearing, the distancing, the hand hygiene, the careful triage of sick, when do you see sick patients versus well patients, all of those things. I would hope that the clinic that you're visiting has those precautions in place, and you should feel empowered to ask, what are the precautions that you're taking, and can you tell me about how you've changed your practices in the current environment?
What do you think about, what are your recommendations to patient families about staying healthy, staying above this? Like, are there any particular supplements that you would recommend, or any particular pieces of advice that you could give to help patient families stay healthy, even as they continue with social distancing, hand washing, mask wearing, that kind of thing?
So I think there will be a session specifically on that later this morning or this afternoon. I will say, looking at the chat, the question was specifically about supplements to boost the immune system, and I would say that the intervention that appears to be the most effective right now at improving the course of disease in hospitalized patients is actually immune suppression. So that's that dexamethasone study that was done in the UK. It does appear that, it's probably patient by patient. So some patients are becoming more ill and having more manifestations of the acute viral infection, but other patients, and maybe a substantial fraction of patients, are actually becoming more ill, not from the viral infection, but from the immune response to the viral infection. And at taking that group of hospitalized patients and applying a broad strategy to them, immune suppression was actually the thing that has been shown to be effective. So I would be careful about that thought process of immune boosting, based on sort of what we see that's really making people really ill with this virus. There are a couple of resources in terms of looking at recommendations around supplements. There's nothing that rises to the level of a clear evidence-based intervention that is broadly effective. We know that there are specific mitochondrial diseases. For example, pyruvate dehydrogenase. We know that there are a fraction of patients that respond to thiamine. We know that ACAD9 related disease, there are likely a fraction of patients that respond to riboflavin. So it's hard to generalize. I would point people who are interested in this topic to look at the NIH review article that was published. I believe it's called Dietary Supplements for Primary Mitochondrial Disease. It's a really, if you just Google that phrase, the first thing that comes up will be the review article that did a really nice job of summarizing like a couple hundred publications of the different doses, the different combinations, the different scenarios that particular supplements have been tried in.
I wanted to ask you about some patients who wear masks out in public, but then, you know, they get dizzy because you're breathing through that cloth. I mean, how do you mitigate that?
Yeah, no, I mean, you make a great point. There are people who are hypoventilating, who have hypoventilation as part of their mitochondrial syndrome. And, I've experienced that. When I'm wearing a mask, it's a little bit uncomfortable in terms of your feeling of being able to take a normal breath in and out. So I guess what I would say is that for people who really have hypoventilation as part of their mitochondrial syndrome, maybe that there are risks of wearing a mask, and potentially discussing that with your pulmonologist or your mitochondrial physician. If you're in a place where mask wearing is mandatory by law, I think it would be reasonable to get a letter from your physician that you could carry with you that says, I'm someone that has hypoventilation, and if I'm feeling like I'm hypoventilating, I may need to pull my mask down. I may need to not wear my mask for a time, and have that letter available to provide. I think the thing to remember is that, again, the mask wearing, the primary benefit is for other people. So if you're one of those people that is, has hypoventilation and has difficulty with that, it's the people around you that are protecting you, and the people that you come in contact with wearing a mask, that's the main protection.
So how are you all holding up in the healthcare field? Having to, you're on the front lines of this. What are your concerns?
So again, speaking as someone who primarily works in a children's hospital, there has not been a spike of hospitalized children. There are definitely children that are getting hospitalized related to this, but they're pretty few and far between, and it's not really exceeding what we see in a typical year in terms of hospitalizations related to respiratory illness. So the pediatric scenario is very different from the adult scenario. In adult hospitals that have been really hard hit by this, for example, in New York in March and April, there have been people brought out of retirement. There have been people who are, quarantining themselves from their family and living in a hotel for months at a time to protect their own families while they work. There have been people who have had to totally change their specialty. They normally do something else, and they've been conscripted to work in respiratory units. In terms of the finances, it's really paradoxical that we could have a healthcare crisis that would result in defunding of our healthcare system. But unfortunately, there will be impacts for a while of the financial situation of hospitals in terms of the resources that they can provide. So those are a few examples that come to mind.
Well, I truly appreciate you taking time out of your busy morning to be here, to be able to answer the questions that we had online, and thank you for your presentation. I mean, we really appreciate it, and all the questions that you answered.
You're welcome. It was nice talking with you, Cliff, and nice talking with all of you out there. And I just wanted to say, thank you all for being here, for being interested and engaged members of the mitochondrial community. So we really appreciate that.
Okay, Dr. Larson, thanks so much. And Power Surge will continue right after this.